Thank you, Dr. Wellen. Our next speaker is Dan Byck. He attended University of Louisville School of Medicine and then interned at Boston University, did orthopedic residency in New York City, and then a fellowship in sports medicine in Mississippi. He is in Ogden now, working in sports medicine. He does arthroscopic treatment for injuries of the shoulder, elbow, and knee. He's the director of the Utah Sports Medicine and Orthopedic Center, as well as the team MD for Weber State Club Sports and high schools locally, as well as the Outlaws soccer team and Snow Basin developmental ski team. And Dr. Byck will be talking about what's new in orthopedics. Dr. Byck.
Good morning. I'd like to thank the Society for asking me to speak this morning. It's a very nice turnout this year. They've charged me with talking about what's new in orthopedic surgery. There are many things that are very new, and we are going to focus on three. Also, we are talking about the sort of the changing state of medicine in our country. It used to be something like this, where everybody was looking at the rainbow and hoping that by the end of their practice they would find that pot of gold. Unfortunately, now it's more like this, and well, we'll see what happens once we get to that website, won't we? Okay, so we're going to talk about three subjects primarily. One will be the minimally invasive anterior approach to total hip arthroplasty. The second will be MACI, or matrix-associated autologous chondrocyte implantation. And the third will be PRP, which many of us have heard about. And as our second speaker mentioned, consumer-driven medicine is taking effect, and we'll talk more about that later. So the term that is applied to total hip arthroplasty is done through an incision that's less than 10 centimeters, is considered a minimally invasive approach. It's kind of like sticking a ship in a bottle through that size of an incision. It's the size of the bottleneck. There are ways to, and the question is, why do we do this? Well, the invasiveness of total joint arthroplasty has led many people to put it off too long. It hurts, the incision's large. There are complications with larger incisions that smaller incisions may prevent. We also, with the smaller incisions, you have a decrease in blood loss and pain. And in fact, you'll see in a second, the hospital stays are markedly reduced, and also the recovery is markedly reduced. There have been 4 mini approaches mentioned. Most of them are just modifications of well-established approaches. Interestingly, the first study or the first published data on doing a minimally invasive anterior approach was in 1949. It was classically known as a Smith-Peterson approach, and it was a larger approach, but it was able to be made smaller in order to minimize the effect of the surgery itself. So the anterior approach, one that most of us have not seen, is quote-unquote a surgeon's approach, and essentially what that means is it's an intramuscular and internervous approach. We do not take down muscles. We do not cut through a muscle that may be damaged or have dysfunction post-operatively. And also, as many of you know, the classic or posterior approach, we actually literally take the muscles off the back of the trochanter, the abductor muscles. And so those will have dysfunction by definition. So although this is not exactly a minimally invasive approach, as you see here, it's more of a cadaveric study, the incision size will be more in line with the little yellow arrow. And what the intent of this slide was to show you that using these large retractors, we can work through a small incision and accomplish the same goals. Some experience that we have, Zach Post is a total joint surgeon who will be joining our group in July. He has been working in Montana and has started doing total hip arthroplasty with a 23-hour stay. He's performed 52 of these, and only one patient required longer hospitalization. All patients are walking the same day. and golfing within weeks in many cases. No postoperative precautions are exacted on the patients, as the risk is essentially non-existent for posterior dislocations. So of all your patients who have had trouble tying their shoes, crossing their knees, wearing those pillows at night, that's not necessary any longer. Where Zach studied at the Rothman Institute, which is in Philadelphia, they've performed over 750 of these types of procedures over the last 3 years and have had a case record of 0 dislocations. It's not for everybody. And maybe we should institute a sequential list of surgeries here and get the gastric bypass taken care of, and then they can have this approach. But we tend to avoid it in patients whose BMI is greater than 30, patients with poor bone quality, osteoporosis, or even chronic steroid users, and also patients with bleeding disorders. We're going to jump now to what eventually we'll talk about as MACI, but first you need to understand what autologous chondrocyte implantation is. It's been ongoing for the past almost 20 years now, as Peterson and Byck first introduced it out of Sweden, for full thickness chondral lesions in a joint. These are typically addressed with ACI or autologous chondrocyte implantation if the size of the injury is greater than 2 centimeters squared. There are alternatives, and many of you have heard about the microfracture technique. It's very popular in the pro athletes to bridge them to something later, but it typically gets a pro athlete through his career. And we can also use a fresh osteochondral allograft, and there's newer products on the market where, in this case, de novo is a minced articular cartilage in a fibrin glue that you literally place into the wound, and it's showing some promise. ACI is a 2 or even 3-stage procedure. Typically, you'll find the lesion on arthroscopy and then counsel the patient on what their options are, and then go back for a second arthroscopy, take a sample of their cartilage, send it to Genzyme, and for a mere $10,000, 6 weeks later, you have a cartilage culture that you can reimplant. The second stage is an open arthrotomy where you place a soft tissue trampoline, we call it, on the lesion, and using fine sutures create a watertight seal. As you can see on the photograph there, those little lines at the edge of the dots are sutures, and that's creating a trampoline that hopefully is watertight, because you have to inject this culture, which is in liquid form, under the trampoline and hope it stays there. The procedure can be performed in almost any joint. Here is an example of reimplantation in a talus. We create the bed and place the trampoline in place. Here it's hard to see, but the sutures are holding the trampoline in place. And then just with a simple needle, just inject it like you would inject anything else. The rehab for ACI is 4 to 6 weeks of non-weight bearing. That's very, very important, as we don't want to literally squirt the cells or the culture out from under the trampoline. CPM, continuous passive movement machine, is employed, and the return to sport is usually 6 to 12 weeks. Months, yes, sorry. We wouldn't be talking about it for 6 to 12 weeks. So what is MACI? MACI is the matrix-associated autologous chondrocyte transplantation, which is, in most of our fields, we try to come up with a cute acronym, and this is what they came up with. So this actually started from a group out of Spain, and it's similar to ACI with the exception that it uses a collagen sponge to implant the cultured cells, and then you can take that sponge and just place it in the lesion. So this is a sort of a paradigm shift in approach, and also the lack of need for an arthrotomy. You can do this arthroscopically, and some studies have suggested that we can actually rehab this much quicker without risk of squirting the cells out. So in this particular study, it shows that they're actually weight bearing from day one. Only 20%, but that's a major difference in terms of recovery. Full weight bearing by 6 weeks. And the 2-year result in this particular study are identical to those patients, those control groups performed with ACI. So here's another study using the MACI. 82% or so were good or excellent results, which is similar. ACI, typically it's about 75%, so within the realm of ACI in terms of efficacy. And that argues to the point of trying to push the FDA to approve this. May see once again, here's a talar lesion. There's the cartoon on the left that demonstrates placement of that collagen with the cells impregnated into it. And then on the right is actually a photograph of that collagen being placed. It's attached with fibrin glue, and it actually does hold against the lesion. I'm not sure how this projects, but that's a second look arthroscopy of the same lesion. So you can see that the hyaline-like cartilage has regrown, and this is much more like hyaline cartilage than the fiber cartilage that develops in microfracture. Here in staining of the cartilage, it shows a quality of the cartilage. The safranose staining and immunostaining for type 2 collagen are similar to what we find in typical articular cartilage. So we have performed over 10,000 ACI procedures in this country. MACI has not been FDA approved yet, but it will facilitate more surgeons being able to do it and correcting lesions that perhaps were left alone or microfractured, where they go on to a quicker recurrence of their arthritic condition. So I think this should help improve outcomes in the long run if it is approved. Okay. One step beyond that is, what about the cells? A really interesting progression in this work has been the characterized chondrocyte implantation. And essentially what Genzyme and others have done, particularly in Europe, is study the cells that you're culturing and essentially score those cells that create cartilage at a higher rate. And then culture those cells, and those are the cells that are produced in the culture that is implanted. So you actually get a higher rate of cartilage production, and more, you may say a cleaner cartilage production in the sense that it's more pure hyaline cartilage. So that's in the works right now. One more jump here to the last subject of our talk today is platelet-rich plasma. It's very much become a consumer-driven product, and many patients have read about this. It's been on TV. It's been in the Super Bowl. Almost every athlete you've heard of who's had an MCL injury has undergone PRP injections. The interesting thing about it is that most of the studies that we have are in veterinary medicine, very few studies in humans, and we are kind of working backwards from the appeal of it to the science of it, and we'll get into that a little bit later. So what is it? It's essentially a concentrated serum, platelets, and growth factors that are used to accelerate a healing response. Pretty simple. It was first used in the 90s in humans by the maxillofacial surgeons as a biologic glue. And what they observed was that it increased bone-forming properties of their surgery and decreased inflammation and infections. It's essentially an aggregation of platelets or a collection of platelets that's in higher concentration than we typically see. But what in the platelets makes this better? What makes it help us? Well, most of us have studied that alpha granules contain growth factors, healing factors, and then, of course, platelets can release fibrin, which is a scaffolding for which cell adhesion occurs. It essentially affects the inflammation phase of healing in acute injuries. High concentrations of platelets, greater than 1 million platelets per microliter in 5 mils of plasma, and the plasma is concentrated between 3 and 5 times the normal serum concentration. We see a release in granules, which in turn release the healing factors. Now, we've also seen progress in chronic injuries, tendinopathies. In this case, Dr. Mishra talked about his success with injecting lateral epicondylitis. This is recalcitrant lateral epicondylitis. These are patients that have failed 3 to 6 months of therapy and have shown marked improvement with PRP injections. Achilles tendinopathy has been shown to benefit as well. In this case, N was small, but we're improving range of motion and we're returning to earlier activity, and in this case 4 to 7 weeks, which is about half of the typical weight-bearing and full weight-bearing activity that you see with Achilles ruptures. Patella tendonitis is a little different. It's an intrasubstance change that causes angiofibroblastic hyperplasia. And once again, in the animal studies, the PRP injections within the tendon itself, which is very different than the injections we typically do in our office, have shown proliferation of, or angiogenic proliferation. This has not been demonstrated in humans, but it has been widely used in humans. Bone healing, multiple studies have shown upregulation of cellular proliferation, and it's been used significantly in distraction osteogenesis, which you've seen those alizaroffs for folks who have lost segments of their long bones or are actually used to help them grow. Really interesting recent studies, and this is very recent. It's a group out of Northern Europe that was presented at the February Academy of Orthopaedic Surgeons meeting, using 150 patients in 3 groups with 50 patients of each group, one with PRP, one with high molecular weight, high alluronate, and then one with low molecular weight, high alluronate. The effects were significant in that they were more effective using the PRP was more effective in younger patients, and also somewhat effective in older patients with more advanced disease. Now, most of these patients had multiple injections, and this has also been demonstrated in Europe for some time. So here's where we are now. You see a Super Bowl coverage of Hines Ward's MCL, how they talk about the doctor injecting the MCL, and he's back in a few weeks. And then many athletes have undergone these, many basketball players, particularly in soccer. MCL injuries are very common in professional soccer and upper-level soccer, and we have seen a very, very improved decreased return to sport. There have been few studies, though, that demonstrate this. But the most impressive N of 1 that I have seen was a baseball pitcher with a grade 2 ulnar collateral ligament, the Tommy John's ligament, early in the season. He was injected, and he returned to pitch in the playoffs effectively, which is, in our world, is unheard of. A grade 2 injury is a season-ending injury requiring surgery, and they can hopefully come back next year at a rate of about 51%. Pro soccer, very active with PRP. Here's a study by Tim Foster out of Boston, who showed that the return to play was reduced by 27%, which in this population is very important. And I would venture to say that those of you who are parents of high school soccer athletes who can take a week off the rehab to get them into the playoffs or the regionals would probably consider this as an adjuvant therapy as well. These are 2 studies that will be presented at the Arthroscopy Association meeting coming up next week regarding PRP usage in rotator cuff surgery. What they have found is they've decreased the leakiness that we see in studies that are post-operative in rotator cuffs. So rotator cuffs are often spot welded as they repair, and there's still a little transgression of fluid from the joint into the subacromial space. In Hranik's study, he showed that decreased the fluid egress by 50%. However, he showed no clinical difference. And Weber also showed no significant clinical difference at 3 months. So we're not sure that it's for everything, but certainly it has its impact in certain injuries. So how do we do it? Essentially, it's a peripheral blood aspiration. We centrifuge it, and then, here we go. And then we draw off the factors that we like to inject. There are probably 15 to 20 different brands or different companies who make a PRP product, or at least make a system where you're able to create a PRP product. Now there we go. And then we inject it directly into the site of injury. As you see, the elbow is a lateral epicondyle injection, and the knee is an arthritic injection. Our battery may be running out on this. There we go. So what do you look for after you inject the patient? Essentially, most patients have a little pain at the site of injection. Occasionally, you'll have an inflammatory reaction. This does respond within 48 hours typically. We ice it and administer acetaminophen. Very important to not administer nonsteroidals within 2 to 4 weeks after these injections. Is it legal? That was an interesting question. Somebody asked me, can all these athletes undergo this? Well, it depends on who you're talking to. The World Anti-Doping Association has banned intramuscular injections for muscle strains or pulls. However, you can declare as an exemption other types of injections and then hope that they approve it. If they don't, then you'll be banned. Pro sports, college sports, NC2A, high schools have no restrictions whatsoever. So in our experience in the office, we've injected lateral epicondylitis, MCLs, Achilles tendons as well. Interestingly enough, they've all done much better than your typical injection course. The recalcitrant lateral epicondylitis may require a second injection. They tend to be the slowest to improve, but in counseling your patients, virtually everything you do to a real serious lateral epicondylitis takes 3 months to get better. Okay, this does cut that time down significantly, but your injections often take 3 months to get all the way better. Surgery often takes 3 months to get all the way better. So as long as the patient's on the same page with you, I think that they'll understand the effects of this. MCLs and Achilles tendonitis returning to sport in 3 weeks is essentially unheard of in our world, and with this adjuvant to recovery, PRP has been a major impact in reducing the return to sport time. I've even injected an MCL PCL injury, and she was playing volleyball in 3 weeks. There's still a lot of questions, though. There's still the science, as we spoke about before. When do you inject these? Are the effects of acutely injured patients similar to the effects of the degenerative chronic conditions? Also, really important, if you're going to be injecting these, do not use local anesthetic. The local anesthetic breaks down the platelets, it releases the granules almost instantly, certainly within an hour or two. The veterinary studies have showed that your release profile is almost instant if it's in an acidic milieu. We don't want to do that. You want to have a much slower release curve of over somewhere between 2 and 4 to 5 days. And then, of course, what do white blood cells have to do with this? Some of the products that are available out there have a very high concentration of white blood cells. And just on the basic, intuitive thinking about that, white blood cells are killer cells, and they tend not to do much in the way of healing other than cause an inflammatory response. And that may be why some of these patients have an increased inflammation after injections. So there are products that do tend to have a lower concentration of white blood cells, and it's very important that you seek those out. I personally think that, in my opinion. Thank you very much. Any questions? Well, there's the topical, the Freon type topical just for the skin, but it's just an injection. It's something that you're going to have to tell your patient, this may hurt, but it will help. We have to hurt you to help. It's tough love.
With the concerns about transfusion reactions and long-term effect on the patients, you mentioned that some of these patients are getting their own plasma returned to them?
All these patients are
all
their
of them.
own.
Okay.
Yes. Well, the candidates are typically anybody under the age of 40 have been shown to do well with these types of procedure, and over the age of 40 had the curve drops off a little bit. But it's with an isolated chondral lesion. As you saw on the slides, all those lesions look like beautiful little dings in the cartilage where the walls are pretty much straight, and you're able to isolate the lesion. The remaining cartilage is relatively healthy. So anybody with those types of lesions would be candidates.
Last question, Dan.
Just a question. As far as referrals, do you do this earlier or do you do it later as far as the injections? I mean, would we do cortisone first and that failed and then go to this, or would you rather have you do this first?
If you did that, the patient will be on the same timeline as they would otherwise. So MCL, the acute ligament injuries, you need to do it. In Tim Foster's study, he said within 72 hours, and that's where he got his results. Many of these patients are within 24 hours. The chronics, of course, that's a whole different story. So that would be the cortisone first, and then if that fails, then you can refer over.
Yes. Is there any difference in the effectiveness in traumatic tendinopathies versus HLA-B27 associated enthesopathies, for example?
Well, that's a really good question. I don't know that that's been looked at specifically. I have not read about that. In terms of chronic disease state tendinopathies as opposed to chronic tendinopathies, I have not read about anybody who's actually studied that. It's certainly worth looking at. That'd be a very interesting study.
How are the PRP injections being viewed by insurances, and if it's not being covered, how much is it going to cost, just on average?
That's a great question. The insurances view PRP as experimental, and although the panels are reviewing whether or not they will include them in their coverage, right now very few panels include them. The costs range from $300 to $500 depending on the product and the system that's being used. It's done in the office. It takes about 15 minutes, and there's no restrictions short of the non-sport restrictions that the patient already has. Okay, thank you very much.
Thank you, Dr. Byck. We'll take a break now and reconvene about 5 after 10. Please feel free to visit with vendors and pharmaceutical representatives outside who have contributed to the conference. Thanks.